Hi, everybody. My name is Allison Gemmel, and I'm assistant professor in the Department of Population, Family, and Reproductive Health. Welcome to our first seminar of the year. I'm delighted to introduce our two speakers today, Dr. Linnea Zimmerman and Dr. Beth Stierman. Linnea is in person, and Beth will be joining us online. So about our two speakers, so Dr. Zimmerman is an assistant professor in the Department of Population, Family, and Reproductive Health. She received her PhD from the same department in 2014 and also has an MPH from Emory University. She has a background in demography and focuses on family planning and women's reproductive health research. She is the PI of the PMA Ethiopia project, which we will be learning about today, a longitudinal study implemented in Ethiopia to evaluate use and barriers to critical maternal and newborn health interventions. Our second speaker, Dr. Beth Stierman, is an assistant scientist in the Department of International Health, also here at Hopkins. She received her PhD in International Health last year and has expertise in program evaluation, implementation research, and quality improvement. Her research aims to improve the quality, equity, and impact of maternal and child health services. So Linnea and Beth, the floor is yours. Thank you.
Great. Thank you, Allison. Can everybody online hear me okay? Okay, I see Emmy is nodding vigorously. Thank you. All right, so it's really my pleasure today to talk to many of you in person, which is very exciting, as well as those online, to introduce the PMA Ethiopia study and really talk about what we've learned from that. And particularly, I'm really glad that Beth was able to join us today to really learn about what delivery care looks like for women in Ethiopia, and particularly the respect and the components of sort of respect and information that women receive during delivery. So I'm going to start. It was working a minute ago, everyone, I promise. All right, I'm going to start with just talking a little bit about the project, some of the objectives of the project, and some very brief, like little highlights and snippets of what we've learned to set the context, and then hand it over to Beth to really go in depth of what we've learned about person-centered maternity care. And then we'll wrap up by talking about what's next for the project, as well as opportunities for students to get involved, because I know that is always of interest. So PMA Ethiopia is a 5-year project. It was started in 2018. It ends this year, 2023. And it's really a collaborative project between faculty here at Johns Hopkins, as well as Addis Ababa University and the Federal Ministry of Health. And the project was started and really motivated by the need for the Ministry of Health to have accurate and up-to-date information about the coverage and utility of a really broad range of services, but really a focus on reproductive, maternal, and newborn health. And so these are a list of just some of the indicators. We have so many more, but I'm really going to focus on the antenatal, delivery, and postnatal care pieces today, in part because that really informs some of Beth's research, but also these has really been the focus of what we've been doing and what the Ministry of Health has really taken up and utilized. So in brief, PMA Ethiopia it's a project, but it's really 3 surveys. So the first one, I'm not going to talk too much about it today at all, is a cross-sectional survey. And we interview across the entire country, women aged 15 to 49. So we randomly selected 265 enumeration areas. You can think of those as like survey tracts, communities. We randomly select those from across the entire country. And then we randomly select from there 35 households and identify women who are 15 to 49. In that survey, we ask a lot of questions about family planning, fertility intentions, role with the partner, education. It's a much broader survey in the sense that it's applicable to all women, but a little more focused on the reproductive health piece. The second piece of the survey is a panel survey. And so in 217 of those 265 enumeration areas, we conducted a census of the entire community. And we identified all women who self-identified as pregnant or were less than 6 weeks postpartum. And we enrolled them in a survey that followed them from enrollment, so during pregnancy or immediately thereafter, and interviewed them at 6 weeks, 6 months, and 1 year postpartum. And that's the data that Beth is going to be talking about, is some of the data that we gathered at that 6-week period to really learn about delivery care and the state and quality of services that women were getting. And then our last piece, and again, not talking too much about it, but just so people are aware of all the different kinds of data we have, is a health facility survey. So we have these 265 enumeration areas. All of them are served by a health post, health center, and a hospital. So that's the primary healthcare system of Ethiopia. And so we identified that health post, health center, hospital, and any private facilities that offered services, and then also conducted a survey there as well. So this map is showing you just Ethiopia, but also these green areas are where we did this cohort study, and this blue, the dark blue, we did the first cohort, and now we have a second cohort that we're also following. And so the data we're going to talk about today is from the first cohort. But you can see it covers a really large portion of Ethiopia, and in terms of population, it's about 91% of the population. So this is just kind of a graphic of what I just said. So we follow up with pregnant and postpartum women at 6 weeks, 6 months, 1 year. And then we start a whole new cohort. So we have, we finished our first cohort last summer in 2022. Nope, sorry. I can't even keep straight anymore where we are. We finished our first cohort in 2021, and we enrolled our second cohort in 2021. So we're midway through data collection of our second cohort. All right, so what have we learned? I've already said this. This is what we did, 3 different time points. And this is just giving you a sense of sort of the number and scale of what we've done in the panel. So we enrolled originally 2,800 women, about 2,800 women in the panel, and we ended at 1 year with about 2,009. And for anyone who's familiar with Tigray, or with Ethiopia, there's been an outbreak of a very extensive civil war in the region of Tigray. And so that happened midway through our data collection. So about 80% of our last follow-up was from that region. Which is just to say that the results that Beth is going to present do include Tigray, but obviously they would be very unlikely to be representative of the situation that is current on the ground right now. But what Beth will be talking about is from this 6-week survey, and we have about 93% response rate at that point. Okay, so what have we measured and what have we found? And I just wanted to give a little bit of background again about sort of why we do all of this. So the first objective of the Ethiopia project is to provide data on coverage of reproductive, maternal, and newborn health services. So what does coverage mean? We're really just looking at what percentage of women are using different health services in the country. And I'm not going to go through all of them because we could literally be here for the rest of the day, but this is just to give you a snapshot of just antenatal care in the country. So this is an example of an indicator that we collect. So antenatal care is an extremely important maternal care service. It's something that is highly prioritized. And for those of you that read maternal health literature, you will often hear this subject needs to be covered in antenatal care. We have to cover danger signs, we have to cover nutrition, we have to cover postpartum family planning, we have to cover vaccinations, we have to cover exclusive breastfeeding, we have to cover birth planning, delivery planning, transport care. We have to cover it all in antenatal care. Half of women in Ethiopia have less than 4 visits, more than half. So 1 in 4 are not attending any antenatal care. And then of those, the majority are attending 1, 2, or 3 visits. So how do you cover all of that when women are only being seen 1, 2, or 3 times? So a priority of the Ministry of Health is 1, to increase the number of antenatal care visits, but to also prioritize the information that women are receiving. A second key indicator is place of delivery. So Ethiopia has still some of the lowest facility delivery rates in the world. They are rapidly increasing. They've gone up from, I think it was like less than 10% in the year 2000 to about slightly over 55% today. So there is rapid increase, but there's still significant percentages of women that deliver at home, both by choice and not by choice. And part of what we want to understand and what Beth is going to talk about is maybe how some of those experiences of care may or may not influence whether or not women return. And so one of the things we see is that 42% of women deliver in their home, and then 32% deliver in health centers. So health centers are generally lower equipped. They're able to handle basic obstetric care emergencies, but not comprehensive. So they don't generally have blood transfusions. They can't handle really much in the way of postpartum hemorrhage. If there's anything complex, women have to be transferred to hospitals, which in Ethiopia, the transport system, the country is huge, roads are not great, and the referral and transport system is a problem. So one of the priorities of the Ministry of Health is also figuring out how can they equip government health centers to better handle comprehensive obstetric care emergencies if that is where women are preferring to deliver. So these are just some examples of how our data are being used in informing real health policy. So this last slide, and I'll come back to it later, is something called the continuum of care. And the continuum of care is this idea that women should receive at least 4 antenatal care visits. And the WHO recommendation is actually 8. So if we did 8 visits, I think you can imagine those numbers would be very low. So this is the number of women who receive 4 or more antenatal care visits, who deliver in a health facility with a skilled birth attendant, who return for a postnatal care visit within 6 weeks, where their health and the health of their infant is checked, and who have the full vaccination schedule at the end of the year. So one can imagine that each of these indicators is higher, but cumulatively, as you go along, there's dropout at every stage. And so one of the really key things that the Ministry of Health has seen and learned from the PMA Ethiopia project is that, okay, we are reaching women, but we're not reaching women at each stage. So why are women leaving? What is it about this care that over time women are not coming back? They're not receiving the full complement of care that they and their infants need for a healthy postpartum period. And I'll come back to this, our last slide, to give more context to Beth's research. So then the second thing that we talk about is not just what services are women getting, but what are they being told in those services? And it's important to remember that this is self-reported. So women may be told more than they remember and report back. I would argue if women don't know that they've been told, then they haven't been told. Like if you don't know that what somebody told you, then the effectiveness of that information is essentially 0. But this is self-report, so it may be somewhat biased. So one of the things we look at is comprehensiveness. Something else that we look at, and which Celia Karp has looked at a lot, particularly for postpartum family planning, is quality. So it's not just what you're told, but how are you treated? So going back to ANC, there's a lot of information that I've said already needs to have information exchange, but there's also key services that are supposed to be part of antenatal care. So we think of those as blood pressure screening for hypertensive disorders. Women should have their weight taken. They should have urine samples for screening for pre-diabetes or gestationally induced diabetes, blood samples, and stool samples, screening for worms and screening for any gestational issues, but also they should also have, not included here, screening for syphilis and HIV. So asking women, did you receive these services? Many women said that they had their blood pressure taken. Fewer each over time until we get to stool sample, and very few women have had a stool sample. So I don't recall off the top of my head what the total number is here, but it is, I believe it's 17%, similar to the continuum of care, that over time, each of these just gets lower and lower. And another key is that there's very large inequities between urban and rural. Urban women are much more likely to receive all of these services than rural women, and much more likely to say that they were screened and told the results for syphilis and HIV. So this is, again, just showing how this data is being used and the inequities that are being exposed. So the last thing that we talk about is, great, now we know who's receiving services, what's covered in those services, but what are the factors that either help people access services or keep them from accessing services? So what are the facilitators? What are the barriers? And we look at a number of things. We have, of course, our socio-demographic information. We also look at partner roles, and Shannon Wood in the department has looked a lot at the role of the partner in influencing care, as has Jess Dozier, one of our PhD students. And then we also look at the health service environment. So this, just referencing Shannon's work, was looking at the role of partner engagement. So we asked, does your partner support you in accessing antenatal care? Do they support you in accessing postnatal care, delivery care, et cetera? And Shannon looked at this just to look at whether or not a partner doesn't necessarily encourage, but there's no discouragement. They're either not engaged or they encourage. And 23% of those women had the full continuum of care. What if they discourage? So they discourage women from seeking either antenatal care or postnatal care. 5% of those women receive the complete continuum of care. Or if they actively discourage both. So they really don't want their partner to seek care at any stage, then less than 3% of those women are likely to receive the continuum of care. So not only is there an issue just with access to services, comprehensiveness of services, but there's clearly very real barriers within the home and the community that are prohibiting women from accessing life-saving care. One of the last things we also, well, I wouldn't say it's the last thing, it's continuous, we live amongst it still, but not an original goal of the project, but one which was added in, was the effect of COVID-19. So COVID-19 occurred halfway through data collection for our first cohort, and we were actually able to look at the differences in some of the indicators before and after COVID in the immediate COVID period to see were there immediate impacts on the health system. And by and large, there were not. I think a lot of people assumed, I think we all assumed, there would be massive impacts for quite a long time on a lot of health services. And we saw that for the most part, there were not major changes in any of the indicators. And part of that is because most of the impacts that we did see were largely in urban areas, and 75% of Ethiopia lives in rural areas. So we did see there was an impact in urban areas. It was relatively modest. There were some significant differences, but overall, it didn't cause major changes to the national picture of what we see. Nonetheless, again, important though for the Ministry of Health to highlight, actually where we need to focus our energy in terms of COVID-19 is in urban areas. They have for a very long time, and rightly so, focused much of their work on improving access to rural areas. But now we see there's actually, this is where the impact is happening. This is where you need to address some of these COVID-19 related challenges. Okay, so I'm going to turn it over to Beth now. But before I do that, I just wanted to bring us back to this continuum of care. So as I said, one of the things that we want to learn about is why are women dropping out of this? And one of the hypotheses that people have, one of the rationales, is that women don't receive good quality care. So if you are attending particularly delivery and you're being verbally abused, you're being physically abused, you have poor outcomes, why would you come back? What would be the advantage? Unless you absolutely have to, why would you return? And so there's a measure that Beth is going to talk more about that's called person-centered maternity care. But we were the first nationally representative population-based survey to include these questions and try to estimate what the experiences of women were in delivering in Ethiopia. So with that, I will turn it over to Beth, and Beth, just tell me when you want me to advance the slides.
Great. Thanks so much, Linnea. Yes, so it's such a pleasure to be here today and to share some of our findings to better understand maternity care experiences in Ethiopia. But before we delve in, I just want to give a little bit of background on why we're talking about this and why it matters. And first, just to say, I think we can all agree that every woman has a right to dignified, respectful care during pregnancy and childbirth. Unfortunately, disrespectful treatment of patients during childbirth is too common, and too little attention is given to ensuring effective communication and emotional support. Several years ago, the World Health Organization led a study in 4 countries, Ghana, Guinea, Myanmar, and Nigeria, that documented the experience of women giving birth at health facilities. What they found was quite alarming. They found that many procedures were done without the consent of the patient. Other patients did not receive pain relief when requested, and 4 out of 10 patients experienced a form of mistreatment. This included verbal abuse, stigma, discrimination, and in some extreme cases, it even included physical abuse. So this issue in itself is a human rights concern. And as Linnea mentioned in this previous slide, these negative experiences also, they undermine trust in the health system and can discourage people from seeking healthcare in the future. All right, next slide. So in recognition of this problem, the WHO and many other global health actors, national health actors, others who are concerned about this problem, decided that they need to put increased emphasis on the experience of care. So there's been a lot of focus in the past on kind of the technical aspects of quality of care. So what procedures are you doing? What checks are you doing? Like, how is that done technically? But not so much on how are people being treated at the health facility when they go there. So what we see here on the right-hand side is the WHO framework for improving quality of maternal and newborn care. In this framework, they really emphasize the experience of care. And they're emphasizing not only the absence of mistreatment, but also positive attributes that contribute to a positive childbirth experience. And those are namely effective communication, respect and dignity, and emotional support. These attributes are critical for providing care that is responsive to the preferences, the needs, and the values of birthing people. And that's what we call person-centered maternity care, or PCMC, as we'll refer to it throughout this presentation. Next slide. So in our study, we wanted to better understand the maternity care experiences of women and birthing people in health facilities in Ethiopia. And we had 3 objectives. So the first, we assessed the performance of a scale to measure PCMC in Ethiopia. Then we evaluated PCMC practices as reported by the maternity care patients themselves. And then last, we looked at differences in the receipt of person-centered maternity care across different subpopulations. Next slide. So to do this, we asked women who were enrolled in the PMA Ethiopia panel that Linnea mentioned earlier about their maternity care experiences. So this was part of the questionnaire that was administered at the 6-week postpartum visit. And since we focused on maternity care at health facilities, our sample included the 1,575 women who delivered in a health facility. We excluded those who delivered at home since that wasn't the subject of our study. Next slide. So how do we measure person-centered maternity care? We used a 13-item scale that had been developed by Dr. Patience Afulani and her team. And that asks questions about communication practices, respect and dignity, emotional support, and support for women's autonomy, which you should recognize from the WHO framework I was talking about earlier. This scale had been validated previously with smaller studies that were done in Kenya, Ghana, and India, but it had not been validated in Ethiopia. So our first goal was to validate its use in Ethiopia. We did this by having the PMA Ethiopia team conduct cognitive interviews with women to check their understanding of these questions and make sure that they made sense in the Ethiopian context. Then we measured the internal consistency of the scale and evaluated construct validity. I won't go into all the details of all of that, but suffice to say that overall we found the PCMC scale performed quite well in this context. Next slide. So this is looking at the 13 questions that were in the PCMC scale. And I'm going to go through kind of the top and the bottom. So they're ranked from the most positive responses at the top to the least favorable responses at the bottom. Next slide. All right. So highlighted at the top, we see the questions related to respect, dignity, and supportive care had more favorable responses. So at the top is the question with the most favorable rating. In that we asked, did the doctors, nurses, or other staff at the facility treat you with respect? Most women replied that yes, providers treated them with respect most or all of the time. So you see here, the dark green, all of those responses there are yes, all of the time. The lighter green is yes, most of the time. And then the less favorable responses are yes, a few times in light pink, and then darker pink, no, never. So we found most or all women said they were generally treated with respect. However, Even for that most favorable question, I do want to highlight the fact that 1 in 4 women reported that providers never or rarely treated them with respect, indicating that there's still some work to be done in that area. Next slide. So now we're looking at the bottom group of questions. And what we see is that questions related to communication and support for women's autonomy received less favorable responses. So for example, we can look at the very last question here. Did you feel like the doctors, nurses, or other staff at the facility involved you in decisions about your care? Most women replied no, or only a few times. Similarly, providers, when asked, they said providers usually did not explain procedures or why medicines were given. And they felt that they were not encouraged to ask questions, or that they were not asked for their consent prior to having an examination done. And overall, half of women said they were unable to deliver in their preferred birthing position. So we really do see there are some gaps here in practices at birthing facilities. Next slide. So we can look at these questions kind of one by one, just as we were doing. We can also look at them in aggregate. So if we were to take all these responses together to create kind of an overall measure of person-centered maternity care, we would have scores in this instance ranging from 0 to 39. And so we give each question of those 13 questions 3 points. A score of 0 would indicate that the person responded no, never to all 13 questions, whereas a score of 39 would indicate that the person responded yes, always to all 13 questions. What we see here is that the mean PCMC score was 19 out of 39 points, indicating that the frequency of positive responses was roughly equivalent to the frequency of negative responses. And as we see here, the experiences varied extremely widely among our sample, from very negative experiences to very positive responses. Next slide. So we wanted to understand a little bit better what characteristics were associated with more favorable person-centered maternity care practices. We looked at different types of characteristics. We looked at individual sociodemographic characteristics. We looked at characteristics related to the birthing experience itself. And we also looked at characteristics associated to the community where the women came from. All of these here had a significant relationship with person-centered maternity care. Notably, women with greater wealth, more formal education, and non-adolescents reported significantly better PCMC. The converse of that is that women of lower socioeconomic status, with less wealth, with less education levels, and adolescents tended to report worse person-centered maternity care. That's perhaps not surprising, but important to know. We also found that being allowed to have family and friends with you during labor improved person-centered maternity care. This also makes sense. We can think about the fact of having someone else there to advocate for you, and also to be eyes and witness what's happening, could encourage better treatment of maternity care patients. At the community level, we found there were geographic differences between regions. And we also found that there was differences between urban and rural communities, with urban communities, women residing in urban communities tending to report slightly better care than those in rural communities. All right, we'll go to the next slide. And we can come back to that if people have questions later. There's just a lot going on there, so I don't want to spend too much time on it all. But overall, I did want to just kind of talk about some of the strengths and limitations of the analysis that we did. So as Linnea mentioned, one of the major strengths of this study was it was a large representative sample, a population-based study. And to our knowledge, there had not been others of that size. So most previous studies looking at maternity care experiences were smaller or non-representative. They also tended to recruit from the facility itself rather than drawing from the population, which can introduce some level of bias in the sample. Second, a strength of our study was the use of a validated measure of person-centered maternity care. However, the study also had some limitations. So we use person-centered maternity care is self-reported. And we know that the meaning that one woman gives to being treated with respect could be quite different than what another woman's interpretation of being treated with respect is. And poor treatment in some contexts can be normalized. So we've seen in certain settings, there is a normalization of not very good treatment. So that could be at play here. And what we would expect to see is kind of what we observed maybe having even greater differences. So when we said there was differences between socioeconomic groups with those with higher education and those that were wealthy reporting better treatment than those otherwise, that gap might actually be underestimated, and it could be greater than what we're actually seeing here. Another limitation was the data availability. So we were not able to investigate all of the provider, facility, and other characteristics that we hypothesized could influence PCMC because we didn't collect all of those variables. Notably, we would have been very interested in looking a little bit more at provider characteristics. So those who were providing care to the maternity care patient. Unfortunately, we don't have some of that data to look at that. One of the ones that we did look at, we asked who provided care. Was it a doctor, a nurse, a midwife, or someone else? We found that there was not significant differences between patients who identified being treated by a midwife versus nurse versus a doctor. However, there was a big difference between those who said, I don't know. And so there is some level of indication that people might be showing up to give birth and not actually knowing who their provider is until they get there. So there's probably things going on there that we were not able to look at fully. All right, next slide. So what does this all mean? I have kind of two key takeaways from all of this. First, poor patient-provider communication and inadequate support of women's autonomy were those areas that contributed most to poor person-centered maternity care. And second, individuals with limited, no or limited formal education, lower wealth, and adolescents reported less respectful treatment by healthcare providers than their counterparts. So these findings call attention to the disparities in care that we see between sociodemographic groups, which really underscore the importance of centering equity in all quality improvement efforts. This is kind of a critical component that needs to be part of any quality improvement work that is done. We also have some kind of point to promising strategies to improve person-centered maternity care. So we mentioned earlier that women who were allowed to have family or friends with them during labor reported better person-centered maternity care, which is an area of interest. So there's been increasingly more research looking at the use of birth companions or doulas or other support persons to be with you in giving care. And we've seen that kind of more informally where healthcare facilities might put in place a policy encouraging you to bring someone with you. And sometimes more formally where healthcare facilities might offer a doula, or there might be doula services that are provided to patients. So there's a potential, an area of intervention that could be done using that. And then lastly, they highlight the need to reinforce effective communication practices and to better support women's autonomy. So to address that gap, there's many things that could be done. One potential kind of area of intervention would be for medical and nursing schools to make sure to emphasize these standards and values in the curriculum and provide greater opportunities for students to practice those interpersonal skills as part of their medical education. Next slide. All right, so directions for future research on PCMC. We identified many characteristics that had a significant association with PCMC. However, even though we did identify some very important patterns, particularly related to the disparities in treatment across socioeconomic groups, there was still a lot of variation that the characteristics don't fully explain. We looked at many ways of kind of slicing the data. We looked at it within communities, across individuals, and tried to really understand those differences. And there's a lot of things that we still don't know. And one of the things that we think this means is that that experiences are influenced by many factors that are difficult to measure in a survey. You can imagine the characteristics of the provider, which we didn't have a lot of information on, interacting with the characteristics of the patient and just kind of personalities, time of day, whether the maternity care was very busy at that moment, morning or evening. Like there's many things that can be affecting maternity care experiences, and we don't fully understand what all is going on right now. So that is an area of potential future research. In addition, more research is needed to develop and test interventions to improve person-centered maternity care. It's not enough to simply measure it, but we need more research on what are the solutions that we could put in place to improve quality care. And finally, one of the things the study did, it demonstrated that we can generate actionable information to guide quality improvement efforts. There are validated measures available, and they can be feasibly collected in large-scale surveys that are already routinely implemented in many low and middle income countries. And we were very encouraged. We were able to share some of our experiences from the PMA Ethiopia study with the DHS program as part of their revision to the service provision assessment. And in the latest revision for 2022, they have incorporated some of these PCMC measures into their exit interviews with clients. And so we're looking forward to kind of having this be a greater emphasis in many different research endeavors that are going on, and that kind of systematic collection of data on maternity care experiences can be used to guide quality improvement efforts and to kind of track changes over time and differences between subregions within countries. So that's another kind of encouraging thing to see moving forward in this area. All right, so I think that actually comes to the end of my slides. I'm going to turn it back to Linnea to discuss a little bit more about opportunities with PMA Ethiopia, and then we'll have an opportunity to open it up to questions from all of you.
Thank you, Beth. So we just have 2 slides left, and then I think. So just an update of sort of where we are currently. So everything that Beth and I went over, as I said, that was from our first cohort. So those data were accurate and up to date as of 2019, which in the way of data is not so out of date. But we have new data. So we are in the midst of our second cohort. We've wrapped up the baseline enrollment surveys and the 6-week surveys. We're just about done with the 6-month, and we're really in the midst of this 1-year follow-up. So we anticipate having that second cohort of women finished by midsummer, and we'll be replicating some of these analyses, looking at change over time. Obviously, a huge global event happened between these 2 cohorts. So what, if any, impacts might we see from COVID, as well as potentially some of those civil conflict issues that we were talking about. We have a 2023 cross-section and service delivery point survey that will be fielded in October, November. And so we'll again have more data on family planning piece and the service delivery point. Not on here is we are intending to develop with Addis Ababa University a longitudinal data analysis course. So we'll be working with PhD students and students from regional universities on helping them use the data. I think of critical importance is making sure that these data are available to Ethiopian researchers and making sure that they have the longitudinal data analysis skills to really lead their own analyses. So we intend to do that by the end of the year. And then the project is set to wrap next April, but the data are publicly available. Anything that we are still collecting will be made publicly available. And so we really want to make sure that those data are used by the Ministry of Health, regional health bureaus, researchers in Ethiopia, as well as in the global community. So with that, the last slide. So what can students do? We have, as I said, tons of data. I think that is the actual scientific term. It is available. So we have Isabella Saria is using some of our data for her master's essay. As I mentioned before, Jess Dozier is working on the data for her doctoral dissertation, but there's a lot more. So if other people want to use it, by all means, there may be a limit of my availability or Celia's or Shannon's, but we will make ourselves available if students have interest. And then there's the potential for RA-ships and field placements. I say potential because that really depends on the needs of the project at any moment in time. we know people need to do their essays. We know people need to do their dissertations. RA-shifts kind of come up as these new field activities come up, et cetera. But I'm happy to always talk about those and what might be available and see if there are activities that align with the field placement schedules. And I know some students here have already reached out to me about that as well. So that is our presentation. So thank you everybody for attending, and we can take questions. Allison, how do you want us to field questions? Do you have any?
Well, thank you. If you want to take one, or if you want to field the questions in person, I can read the ones online. We already do have 2 questions online, but I want to open it up to students first.
Yeah, we have a question here.
Great.
Thank you so much for this really excellent, exciting data. I'm particularly heartened to see the questions being incorporated into the DHS in some capacity. I'm curious about some of the kind of relative meaning of those measures of respectful care, particularly in terms, and I don't know if this is data that you have, but particularly in terms of the kind of relative weights of those different measures according to women and birthing people who answered these surveys. So like if a large majority of people said yes all of the time they were able to give birth in a particular position, but actually that wasn't particularly meaningful relative to some other measure. Yeah. Just as we think about, some of the disconnect between the care people are receiving and whether or not they return, how one small thing that occurred that may weigh very heavily may outweigh many other forms of respectful care.
Yes, absolutely. Beth, were you able to hear the question, or do you want me to repeat it?
Yes, no, I heard the question perfectly. And I think it's a really good question and good reflection. Certainly what matters the most to different people varies. And I think the more that we can do to really listen to those who are receiving care, it's we should be doing, not kind of imposing things upon people based on what our value is. And so that, that's really the idea between person-centered maternity care, is to listen to the values, needs, and preferences of birthing people. That said, the values, needs, and preferences of birthing people are probably going to vary amongst, people. So in this particular scale, it is an equal weight is given to each of those 13 questions. It's partly just for simplicity, but also because there isn't good research right now to say what matters most to different people. And I'm sure that it will vary in different contexts. But I think certainly at the kind of facility level, there's increasing interest in kind of looking at this to guide health facility quality improvement efforts, locally, as well as being able to collect this data kind of more nationwide. And I think incorporating qualitative interviews and questions around experiences and really listening to those, receiving care in that community can be very helpful to guide those efforts and make sure that those preferences are part of the work that's being done. I don't know if that helps kind of answer your question, but in short, this particular study weights everything equally, but I agree with you fully that we need to listen and understand what matters most for those reasons.
Thank you.
Great.
Allison, we have another question here in the room.
Oh, okay. Do you want to take that first? Yeah.
Yeah, it's from a student. So Anna, go ahead.
Thank you. Thank you so much for the talk. This was really helpful. And I think in my experience, like person-centered care is probably the buzziest buzzword in all of healthcare at the moment. And so, I've had like professional experiences where I've sat with clients and they're like, well, what is it and how do you measure it? So I think this was really helpful to see that there are like initiatives and work being done on how to like make it a more concrete concept. I was just wondering, is there any kind of initiatives really anywhere that you might be aware of that try to create like quality metrics from some of these things and then tie it to the performance of healthcare systems, either with like payment incentives or something like that? Or is that like, are people moving towards that at all or not really?
Beth and Andrea, I see nodding of your head. So maybe you guys want to add, and I can add about Ethiopia specifically.
Yeah, that's a great question. I went to ask, so my PhD advisor, Andrea Carregna, is here with us and is also has been such a wonderful mentor to me. And I was going to ask Andrea if you wanted to answer that question kind of about what's going on.
Yeah, thank you. A great job, Beth, again. So I do think that we are, for the first time, we are seeing this measure actually being used. It was first used and proposed for use for the DHS program in the SPA, during the SPA revision process. So that was the first gain that we have had in this area. So for the first time, we actually have a measure for, looking at experience of care in LMICs specifically. But more recently, with support from UNFPA, UNICEF, WHO, and also Columbia University, we are looking at, we call the project a revisioning EMOC, so emergency obstetric care. So we are looking at all sorts of, quality of care metrics and how best to integrate them, how best to use them for measuring access to emergency obstetric care, both basic and comprehensive. And also, as part of that process, we are looking at experience of care in tandem with provision of care. So this is pretty much where the field is going right now, trying to integrate experience of care measures and definitely this measure that Beth presented on into the larger picture, looking at quality of care more broadly and using, some of the other measures that exist, some of the other quality of care indicators that exist already. And I'm going to put a link in the chat to a paper that was recently published from this work. I hope this answers the question to some extent, at least.
Yes, thank you.
And I'll just add about Ethiopia specifically. So Ethiopia Ministry of Health, I think, is really unique from a lot of ministries of health. They are very evidence-based. They're very data-driven. They really do use data to inform policy. That said, they are not unique in that it is slow. It is very slow. So, and they don't want to make change based on one data and one survey and one paper. They want to see these from a range of data sources, a range of different studies. So I think the health sector transformation plan is this specific program and policy they use to track the success of their health system. And it's very much based on maternal mortality rate, maternal mortality ratio, newborn mortality rate, et cetera. It's those, those key indicators that you can generally estimate. But they do very much recognize that quality is integral to achieving those goals. And so I don't think at this time, the health sector transformation plan is revisited every 5 years. They just did it. There's not going to be another revision in the near future. But I think that they are very aware of the role that quality plays, not just in maternity care, but family planning and in other services as well. And so I don't think there's a specific quality metric, but they do work on initiatives to improve quality. And I could talk a lot about family planning ones, but there's another question, so I will not. Allison, is it okay if we take one more student question in here?
Oh, sure. Yep.
Okay, thank you. So you mentioned the continuum of care and then how women are leaving as the stage progresses. And you made me think of the self-care intervention that WHO is promoting.
Mm-hmm.
Do you think that it will be kind of like a useful solution to fill in the gap to make sure women are getting some kind of like sort of care? And I can think of like some reason that might be like hopeful overall improving experience of care, but I can think of some reason that might not be feasible in Ethiopia. And I just want to know your opinion.
Sure. So I can add, and then Beth or Andrea, if you have anything to add about sort of potential for self-care initiatives. So I would say one of the biggest challenges probably is that you cannot generally effectively self-care a delivery. So, no matter what, if there's any kind of complexity, even if you're extremely good at delivering babies, you're not, it's going to be something that generally you have to have a skilled provider if they're going to handle any kind of emergency. So if you're thinking about the continuum, everything else could be self-care, but that would still be why women are not achieving the continuum for that piece. But that said, there are some intervention. So you can give women misoprostol to self-manage postpartum hemorrhage if they are delivering at home. And there has been clinical trials that have community-based clinical trials that have demonstrated that the provision of misoprostol to women to take after delivery is successful. There are Probably some, so the Ethiopian health system has a very active community health outreach program. It's called the Health Extension Worker Program. And they have it, they are volunteer for the most part, women who work with communities on basic things like hygiene, nutrition, and things like that. And I think that's where maybe more of the kind of self-care through health promotion kind of activities can come in. Otherwise, things like, vaccinations, hard to do through self-care, particularly because electricity is still a major issue. So cold chain storage is a problem. But I think that self-care is definitely, it's something that's it's also a buzzy word that is something that people are really focusing on, but it wouldn't be the solution to the continuum of care just because some of those things really do, for the most part, need to involve a skilled and trained provider. Beth, do you have anything to add there?
No, not really. I mean, I think that really is, in that context of like childbirth, I think it's a little bit more complicated to talk about self-care for the reasons Linnea mentioned, but part of the person-centered maternity care thing is about supporting women's autonomy, which is being part of the decision-making process, getting to decide in what position you would like to deliver. So there's some of the kind of values and principles behind self-care we see when we talk about person-centered maternity care, but it's a little bit more complicated. Even for deliveries that happen at home, there is really a push to have a skilled provider there. And that's having a skilled provider is kind of one of the recommended things for maternity care.
Oh, one more question, and then, sorry, Allison.
Okay, that's fine. We have about a little less than 15 minutes. Yeah.
Okay, Huda.
I just have a logistics question. Early on in the slides, you showed the A and C. If you could flip that back to that, I just wanted to know of the ones that were like 1, 2, and 3, were they? Yes. Okay, so of the 1 to 4, is that, so that's the percentages are of the women that had any?
This is so it would be 23% had 0, of all women, 23% had 0, 6% had 1, 10, 18, 43. It should add up to 100. I think it adds up to 101. There's a rounding error. So 43% of women had 4 or more visits. 3% of all women had 18% of all women had 3 visits. 10% of women had 2.
Okay, so it's from all of them.
Yes,
Okay.
yeah. The purple should be the 6, 10, 18, 43.
Okay, thank you.
Which doesn't quite sum. Again, rounding error. I caught it after I sent the slides. Sorry.
Great.
Okay. Go for it, Allison.
All right. Well, we have 3 questions. So I'm going to start first, one from Emily Agree, because it related to something that's already been discussed. So how does PCMC differ from or is similar to person-centered care more generally? In other words, is there systemic sexism that affects maternity care more than other types of care? Seems relevant for thinking through potential interventions.
Maybe I can respond, and then Beth, you want to jump in, and maybe Celia can also add a little bit about family planning care. So I think it would be hard because obviously maternity care is generally specific to females. It would be hard to obviously compare the levels of sexism inherent to that. I think one of the things I know that the MAGE project in international health is trying to think about is ways to actually measure some of the gender dynamics of the health system. And we can't do that in Ethiopia. That's not the breadth of our project. But one of the things to think about is how we can incorporate some aspects of gender into the health system survey. So how many of providers are male versus female? How many doctors are male versus female, nurses, et cetera, getting some sense of that dynamic, as well as I was honestly just thinking when Beth was talking, we don't ask what was the sex of the person who delivered the child, and does that matter? And might we see differences in quality of care or person-centered maternity care based on the sex of the person who's the birth attendant. Not getting to your question exactly, Emily, but just thinking about, you know, how we could evaluate maybe some levels of sexism or gender-based issues in the delivery of maternity care. To my knowledge, and again, Beth or Celia might have more, I don't know that there's much in the way of person-centered measures sort of outside of reproductive health and maternity health.
Disability community.
Disability, okay, so Anna's saying the disability community has some. But I'm not sure if it's really entered into this sphere of things like primary care or you know,
Dana just said
cardiovascular
there's a
care, et
lot in
cetera.
primary care too. So
Well, Dana, all right, thank you. So perfect.
something to explore. Oh, Dana can
Yeah.
say, yeah.
Yeah, I can send you some resources. Person-centered care is a big thing in like health policy. At least in the domestic, at least I know in the US domestic context. So
This is why I should not speak of that I do not know. Beth, go ahead.
Yeah, no, I was just going to agree that I think the term person-centered care has been kind of hot in the United States talking about health policies, but I haven't seen a lot of talk, and I think this could be changing, and it might also just be my unawareness, but less measures for person-centered care in international settings. And I know one of the things that had come out of the DHS SPA revision process was the need for more person-centered care and care experience questions across the board. So not just for maternity care, other groups who are talking about other quality of care metrics, we're also talking about the need for that in other areas. I hope we'll be seeing more of it kind of going forward.
Can I speak? I just want, thank you. I just wanted to say, I think you can't do it with your study, which is phenomenal, and it's so fascinating. But the two issues you raised about respect for autonomy and communication made me think about whether those issues are pervasive to the way medical education is sort of instructing physicians to respect or not respect patient perspectives, or whether there's an overriding, especially in different countries, an overriding sexism that's affecting the extent to which they bother to, they respect the women who are their patients when they are women giving birth. And so I think without going beyond your own study to other research on patient-centered care in the same context, unfortunately, it's hard to know exactly what needs to be done about things like physician education in these contexts to make sure that they're getting the message. So thank you, but it's great, fascinating work.
Sorry, Allison, I think there's some responses in the room. First, just to say that Caroline and Cynthia, both physicians, were vigorously nodding their heads about the issue of physician training. And I think, Beth, Frederick, you wanted to say something, and then Caroline.
Yeah, it's a follow-on to Emily's intervention or remarks, which is that one of the, you talked about how you're going to deliver these findings to ministries of health and the community in Ethiopia. One of the advocacy efforts from advanced family planning that's been somewhat easier and more powerful is changing curriculum for healthcare providers. And it is easier to go in and say, this is something you can do because it costs nothing for them to do it.
Mm-hmm.
And so I would just recommend that you think about that as you go into your dissemination.
Yeah, thank you. I think that's very helpful. And we have a project advisory board, and on that, sitting on the chair of our board is the Deputy Minister of Health for Ethiopia. But part of that as well, we have the president of the Ethiopian Society of Obstetrics and Gynecologists and the president of the Nurses and Midwives Association, who both have a lot of role in the curriculum development. So we also have some avenues for exactly that kind of dissemination and intervention. I think Caroline wanted to say, sorry, Allison, I feel like I'm taking over your MC role here.
Can you hear me or not?
Yeah.
Okay. So I have a question or comment, which is like, so I think this is fabulous work. I think the measure is comprehensive, but at the same time, I think there's maybe a little more work to think about how to use the measure to inform what kind of intervention. And I'm absolutely nodding about provider training. And one of the questions I had communication is really a big issue here based on your data. And I think the issue of communication looks very different for a normal delivery versus a complicated delivery. And I don't know if in your data, you can kind of discern that, because the issue of communication and what treatment I'm giving you in an emergency looks very, very different than in a normal delivery where there's time. And the second thing is just depending on primary care versus non-primary care, is this just one provider that has multiple tasks at the same time, including that delivery, versus in a hospital where there are more people. Because in that case, it might not be the provider who doesn't know how to communicate, but the context that needs fixing. And I think both needs fixing, but I think looking at your data around, how the communication issues are more problematic or not in context of complication versus and primary care would be helpful.
Yeah. Beth, do you want to say something?
Just to say briefly that I agree completely that those would be really important things to look at. Some of the things that we were able to measure with our data, and as I mentioned, there was a lot of things that we weren't able to look at, but we did look at how was person-centered maternity care, whether or not the woman had a cesarean versus vaginal delivery. And perhaps encouragingly, and we didn't ask whether it was, it was an emergency cesarean or a scheduled one. So it's a little bit hard to know, but cesarean reported higher on average than those who didn't, which was encouraging in some ways for a more complicated procedure being done, that people were potentially asked for their consent and having more explanations given. That said, we did ask whether there was any based on whether the patient had complications, and if their complications were reported, they tended to report for personal care. I think there's a there. It's a little bit hard to disentangle with the patient that we have.
Great. So I'm aware of time. We have 3 more minutes. I'm selfishly going to ask one of Dana's questions, which I think can be answered really quickly. Is there a way to leverage these data to see if CMC was associated with whether a woman continued her ANC in subsequent care? So kind of that's what we're setting us up with. So quickly respond to that, and then we'll move over to David, who has a question.
Yes, so I can quickly respond to that and say yes. And that's one of the things that I think there's potential to do with the data from PMA Ethiopia. With Celia Karp, who I can't see, but I think she's there in the audience. We've looked at postpartum family planning and whether PCMC is associated with uptake of that. And so you could also look at, well-child visits and immunization for the newborn. There's some measures that we could look at there. And I think it's really would be an interesting study or analysis to do.
Great. We look forward to hearing about those results. Okay, David, on to you.
Thank you. Allison, you asked one of the 3 questions. I just wanted to observe that you don't have to go to Ethiopia to see the same problem here domestically. We're dealing with it. We're dealing with it here with WIC and the issue of retention and return visits and a whole panoply of problems associated therewith. However, when we've been looking at it, first of all, it's a very heterogeneous issue, certainly in the U.S. with respect to assigning a particular or even a cluster of factors to this. I have found it helpful to look at it from a clinical perspective, administrative perspective, and environmental perspective, and of course, above all, the client's perspective. And by that, I mean, I think comments were made with regard to the provider, the circumstance of the provider, but also in terms of administrative considerations, waiting time, ability to make appointments, number of children that you have in your lap or you're bringing in with you, the problems of lost work, lost time, even if one is not working for funds, and so on. So by breaking this apart into multiple components, you may get a better read with regard to where the problem exists. And certainly no question that providers need to be continually in service education with respect to being respectful, because above all, every one of us wants a modicum of respect. And then ultimately, I'll leave it at that because I'm looking at the time. But thank you for giving me an opportunity to share that with you. It was a really great presentation, and I've picked up several clues that we can apply here. Thank you.
Wonderful. Thanks for those comments, David. And thanks everybody for a really stimulating discussion. And thanks especially to our two speakers for sharing this. As Andrea noted, the paper is published. So if you want to learn more, please feel free to look at the paper published in PLOS. Is that, am I right? Where is it published?
It's published
No.
Job Global Report. So the American
Okay.
Obstetricians and Gynecologists.
Okay, great. All right, thank you so much, everybody. Have a wonderful day and rest of your week.
Bye. Thank you.
If you hear anything more about it. Yeah. Thanks.